This chart compares healthcare spend per capita against life expectancy among OECD nations. The United States spends almost double what most other advanced economies do, yet we see measurably worse outcomes, including lower life expectancy and higher infant mortality. Because of the high cost of a hospital visit, millions of Americans check their bank accounts before deciding to see a doctor. Manageable conditions are often left untreated until they become expensive emergencies. This financial barrier to early intervention explains why younger Americans die earlier than young people in peer nations, dragging down the overall national life expectancy. High costs and administrative friction discourage the very preventative care needed to keep a population healthy. This creates a unique problem. If the U.S. were to demolish this system and replace it with something efficient tomorrow, the shift would likely trigger a massive economic crisis. This bar chart shows total consumer spending across peer nations. While the United States has the largest consumer market in the world, removing healthcare spending puts our consumer activity perfectly in line with other advanced countries. This means 10% of our entire GDP goes strictly towards the wheels of medical bureaucracy. That 10% represents millions of administrative jobs and an immense financial apparatus built to manage the friction between competing healthcare interests. The system functions as a balanced ecosystem of administrative bloat, where every inefficiency creates a job, a fee, or a profit margin for a specific stakeholder. The first node in this incentive map is the physicians. Becoming a doctor requires navigating an immense upfront financial burden, with students at private colleges often graduating with as much as $400,000 in debt. The Association of American Medical Colleges, or AAMC, tracks this student debt burden and predicts a shortage of over 130,000 physicians by 2033. To protect physician earnings, the American Medical Association lobbies Congress to limit residency positions, bottlenecking the supply of new doctors as the population grows. Regulations further waste physician time by requiring specialists to perform basic data entry and insurance justifications that could be handled by a receptionist. Restricting the supply of doctors while forcing them to manage bureaucratic paperwork intentionally inflates the cost of a physician's billable hour. The second node involves hospitals. Private equity firms have strategically bought up independent practices to create local monopolies on care. These monopolies use all-or-nothing contracts to strong-arm insurance companies into covering their most expensive facilities, regardless of patient need or cost-effectiveness. Pricing is further influenced by the Specialty Society Relative Value Scale Update Committee, or RUC. This physician group frequently overvalues specialist procedures when advising the government on healthcare costs. Because the prices suggested by the RUC are almost always adopted by Medicare, they act as a foundational price floor for the entire medical industry. Hospital consolidation eliminates free market competition, allowing regional monopolies to dictate inflated prices for baseline care. The third node consists of health insurance companies. They act as middlemen, using complex employer healthcare plans to obscure the true cost of care from the patient. Their financial incentives encourage them to delay or deny claims, adding immense administrative costs just to negotiate with the hospital networks. This opaque pricing environment provides cover for pharmaceutical companies to charge the U.S. market significantly more than the rest of the world. The U.S. generates 40% of global pharma revenue from just 4% of the population, meaning Americans subsidize drug research for the planet. Insurers and pharmaceutical companies thrive within a system so opaque that a patient in crisis has no way to shop around or negotiate prices. These groups employ armies of administrators to lobby, sue, and out-negotiate the others, leaving the patient trapped in the middle with the least bargaining power. The scale of this defense is massive. The healthcare sector spent nearly $750 million on federal lobbying to protect these specific interests. Decades of weak antitrust enforcement by the FTC have allowed these anti-competitive practices to cement themselves into the broader economy. Another slightly darker visual metaphor is that often rats will get their tails caught together, and as they run to try and free themselves, they only end up pulling the knot tighter. Other nations offer working alternatives. Australia uses a blended system of public Medicare and private insurance to achieve excellent health outcomes while maintaining well-compensated doctors. Adopting such an efficient system in America would instantly wipe out 7.5% of U.S. economic productivity and shed millions of administrative jobs. Deflating this bubble requires aggressive antitrust enforcement to break hospital monopolies, strict lobbying regulations, and extreme price transparency to force competition. Removing the fear of medical bankruptcy provides the security needed for skilled workers to start businesses and for the population to live longer, healthier lives.